Right, welcome everyone. We continue with our discussion of nephrology. Okay, so now we have interesting case. Okay, so you have a 63-year-old comes in with irregular nodule or firm nodule in the right lateral lobe of prostate. This is pretty risky stuff. So you check PSA. PSA is normal. One, what do you do next step? You don't care about PSA. PSA is nothing. So you do TURB, transurethral ultrasound biopsy, ultrasound guided biopsy. Okay. So when do you do ultrasound prostate biopsy? When there is a digital rectal exam causes a prostate nodule indurations or asymmetry independent of PSA level, or when you have rising PSA level more than 4 and or the rate of change or density increases. Okay. When do you do repeat biopsy? You do repeat biopsy if there is inadequate sample size on the initial biopsy and if there is continued clinical suspicion based on the serum PSA or symptoms. Okay. Or if there is abnormal histology on the initial biopsy, like atypical small acinar proliferation, then you need repeat biopsy to confirm exactly what grade of prostate cancer. Are we dealing with? Okay. Now another case is kind of interesting. You see 66-year-old have JVD distension, okay, and small voltage QRS and EKG plus protein urea, and they ask you what is the diagnosis. This is a primary amyloidosis. They can give you an EKG picture and then proteinuria, and then this is likely primary amyloidosis. Okay. Now, so you could ask what other features of amyloidosis other than proteinuria and peripheral edema. It could cause cardiomyopathy, restrictive cardiomyopathy. That's why you have JVD distension and low voltage QRS, conduction defect as well. It could hit the brain, but basically it's amyloid protein, could go everywhere. Okay, it damages all organs, could worsen. Okay, it could cause all kind of symptoms. So if it touches the brain, causes peripheral or autonomic neuropathy, stroke. It can touch the GI, causes hepatomegaly, dysmotility, malabsorption, GI bleed due to vascular fragility. It could go to the lung, causes pulmonary nodule, tracheobronchial infiltrate, and pleural effusion. Could touch the musculoskeletal system, causes enlarged tongue, shoulder pad enlargement as well, and can cause a thickening of the skin, subcutaneous nodules, ecchymosis, periorbital purpura. Hematologically can cause anemia and thrombocytopenia as well. So it literally can cause everything. It's an awful disease. Okay. So now we get a patient who's 67, came in with hematuria. Okay. 3 days ago he had an episode of hematuria that resolved spontaneously. So you do urinalysis. Urinalysis shows blood. Okay. And they're asking what is best next step. Best next step, you want to do CT urography followed by cystoscopy. Okay. This is like the third question on cystoscopy. Even if the patient is taking antiplatelet, okay, or anticoagulant, it's usually uncommon to just cause hematuria, even if they're taking antiplatelet. So you want to rule out malignancy. Okay. Okay, now this case is kind of interesting. So if you see somebody, a 40-year-old woman, came in with chronic kidney disease, came in with intermittent black bilateral back and bilateral flank pain. Okay. Weight loss. So flank pain, weight loss. Start thinking of something serious. Maybe is it cancer? Is it something serious? So, and then you see there is digital clubbing, mild to moderate dilation of calyces without dilation of the mid to distal ureter. Okay, mid or distal ureter. This, and they ask you about the diagnosis. What could be causing it? This could be retroperitoneal fibrosis. Okay, this could be caused by retroperitoneal fibrosis. Can cause these symptoms. And that's a trick, you know, dilation of the calyces. If you see dilation of the lung, this is bronchiectasis. It's kind of like the same thing. It's a good idea to remember. So, retroperitoneal fibrosis. There's early stage where you just have pain in the lower back, flank, abdomen, usually dull. You can cause weight loss, anorexia. You can have claudication due to arterial compression, gross hematuria, possible testicular pain, IBC obstruction leading to edema or DVT as well. This is the early features. Late features can cause progressive urethral obstruction, mild, mid to distal. Oliguria, flank pain can cause that. Lab, you have elevated ESR, elevated CRP, elevated ANA in 60% of patients, anemia, normal urine sediment as well. Imaging, ultrasound showing poorly marginated peri-aortic mass, usually hypoechoic with hydronephrosis, and CT scan causes peri-aortic retroperitoneal mass, possible IVC compression and lymphadenopathy. So this is retroperitoneal fibrosis. Now another case seems to be high yield. This is the second question on the same thing. So 37-year-old woman had renal transplant, right? Due to end-stage renal disease or whatever reason. Okay. So when they're transplant, automatically they're going to be on tacrolimus, okay, or cyclosporin. Okay. And now she had GERD. You know, normal people can have GERD, not just transplant. So they give her lansoprazole. Now she developed AKI. And they're asking why or what to do next, okay? So what do you think is going on? Here, it's tacrolimus toxicity. Because there are certain drugs that increases tacrolimus level, like macrolide antibiotics, itraconazole antifungals, ACE inhibitor, calcium channel blockers can cause that, lansoprazole, if you take for GERD like in this patient, or grapefruit juice increase drug level cause toxicity. There are drugs that decreases level because affect cytochrome P450, right? There are drugs that one that decreases level is antibiotic like nafcillin, rifabutin, anti-seizure medication like carbamazepine, phenytoin, or others like octreotide, St. John wort, or Lestat, okay? These decreases drug level, okay? Now, also you want to know the side effects of tacrolimus and cyclosporin. They could cause renal side effect, cause renal failure, bland urinalysis, which is most common. Other side effect can cause hypertension, vascular hypertension, can cause the neurological side effect like tremor, headache, visual difficulty, can cause metabolic issues like hyperglycemia, hyperkalemia, hypomagnesemia, you know, and cause increased infectious risk of course, obviously, because it suppresses the immune system. And could also increase risk for malignancy. Cutaneous squamous cell carcinoma is a common one, and lymphoproliferative disorder. So all of this can happen after transplant. So there is a risk for transplant, okay? But now the second question tell you, why do you do transplant? Do you transplant, okay? Because it has the highest survival benefit, okay? So that's why we do transplant. So with despite all of these side effects, still a good option, okay? Now you have somebody came in, like a lady came in with follow-up, just follow-up, 52, woman, has no major issues. Calcium is 12.1, okay, you found that on labs. So what do you think is causing that? What's the diagnosis? Okay. Is it malignancy or adenoma? This is parathyroid adenoma. Okay. And here's the trick that you wanna know. If the calcium it's like above 13 or 14, then this could be malignancy. If it's 11, 12, this is parathyroid adenoma, okay? And it is the most common cause of hypercalcemia, okay? So sometimes hydrochlorothiazide can cause hypercalcemia as well, okay? But a lot of the time PTH adenoma is the most common one, okay? Okay, so here is very important high yield case scenario. So if you see 49-year-old alcoholic came in with diarrhea and abdominal pain, okay? So you have diarrhea, abdominal pain, and he's alcoholic, diarrhea, abdominal pain. So what do you do for this patient? You give him thiamine and 5% dextrose, okay? So 5% dextrose, what does it cause? And also receive supplementation for magnesium and potassium. This cause, and then the patient develops severe weakness, and hypoxia, agitation as well. And the question is, why is that? Why is the patient having all of these symptoms? And the reason is, could be hypophosphatemia. This is a very tricky question and you need to know why. So what could be causing hypophosphatemia? Okay, so there are three reasons: either internal redistribution, or decreased intestinal absorption, or increased urinary excretion. One of these three things. So when do you have internal redistribution? If there's increased insulin secretions, especially in refeeding malnourished patient, you have a lot of insulin phosphate drops because all the phosphate goes inside the cell. Or there is respiratory alkalosis, stimulated glycolysis as well, and hungry bone syndrome after parathyroidectomy drops the phosphate as well. This is one thing. Second thing, decreased intestinal absorption. Like if somebody have chronic poor intake, somebody have aluminium or magnesium containing antacid that bind phosphate, if you have steatoturia or chronic diarrhea as well. Or there's increased urinary excretion, like primary and secondary hyperparathyroidism. If there is vitamin D deficiency, decreased GI absorption, increased urinary excretions. Or if there is a primary renal phosphate wasting syndrome or Fanconi syndrome. These all causes hypophosphatemia. Okay, and that's how it presents usually: severe weakness, agitation. So phosphate below 2, you can do oral replacement with phosphate. If less than 1, then you do IV phosphate. You need IV phosphate for this patient. Okay, now you see a patient. So now you see a patient, interesting case. You see 53-year-old man have ESRD, hemoglobin is 8. So what do? You give erythropoietin. But you give erythropoietin, still no response. What could be causing that? So you check iron panel. You see ferritin 182 and the transferrin saturation is 15%. And they tell you, okay, what to do next, or what could be, how to fix that. So you fix that by giving IV iron. I mean, erythropoietin stimulate the production of hemoglobin, but you need the raw material that produces the hemoglobin, which is the iron. So you give iron until ferritin is above 500. Till ferritin above 500. Okay. So what are the things that causes erythropoietin resistance? Like erythropoietin make it ineffective, doesn't work. Iron is the most common when there's low. B12 folate as well. So you need the raw materials. Okay. Sometimes there's fibrosis, myeloproliferative issues like myelofibrosis, myelodysplastic syndrome, red cell aplasia, hemoglobinopathy like sickle cell. Like if the mechanism is defective, erythropoietin is not going to do that. If there's cancer like multiple myeloma malignancy, wouldn't help. If there's HIV, hemodialysis, infected hemodialysis line as well. If the patient is on ACE inhibitor, believe it or not, will make it ineffective. Another thing, if there's inadequate dialysis, chronic inflammation, hyperparathyroidism, also make erythropoietin not very effective. Okay. Now, you see this patient after a prostatectomy, like this 75-year-old had prostatectomy, radical prostatectomy for prostate cancer. And then after that you have decreased sensation, and like you have loss of control, involuntary loss of urine after straining. Okay, urine loss after straining. Okay, and there is decreased sensation, okay, in lower extremity. And then they tell you, okay, what's best next step management? The management is pelvic floor exercises with biofeedback. Okay, this is how you do manage this patient. You do pelvic floor exercise with biofeedback. Why? Because urine incontinence is common after radical prostatectomy for localized prostate cancer, and usually you do damage urinary sphincter. So what you want to do, you want to do pelvic exercise with biofeedback can accelerate the recovery and decrease the incidence of post-prostatectomy stress incontinence. Alright, so now let's summarize what we talked about. We talked about biofeedback for after prostatectomy would be very helpful. We talked about how to keep, I give iron to ferritin above 500 and resistance for erythropoietin. Talked about hypophosphatemia, PTH adenoma, highest survival benefit in transplant, tacrolimus toxicity in transplant, retroperitoneal fibrosis. Talked about cystoscopy, amyloidosis, and prostate transurethral ultrasound guided prostate biopsy. Thank you for listening.